Well, thank you very much for the invitation. I'm going to start by sharing our journey with you and by telling you a story. So whilst living in Kenya in the last month that I was there, I had the privilege of meeting these two ladies who had previously been best friends, but for the prior 10 years had literally not seen each other because they'd both gone blind. This was the moment when we finished one of our clinics and we were calling out their names to take them to the hospital for surgery. And it was the moment that they actually realised they were sat next to each other. From that point on, this lady grabbed hold of her friend and stayed with her the whole way through, all the way to the operating theatre when we had to separate them for their treatment, all the way to after. And we're going to come back and revisit them shortly. But they're two of 39 million people globally who are blind. And of everyone that's blind in the world, 4 in every 5 are blind from conditions that we already have cures or we know how to prevent. And it's not just the individuals affected by blindness, it's their families, it's their communities. So this is a midweek clinic that we were running. And if you look carefully, you see up at the top, a blind man with a grandchild, and same here. So for every person that's blind, the knock-on effects are often really significant. So here we've got 2 kids not going to school because their parents or grandparents can't see. And if you look worldwide where people are blind, so this map is distorted to show where blind people live, the majority are in Asia and Africa. And whereas if you look at where the eye care providers are, they're all in the Americas and in Europe. And the place of greatest disparity between need and opportunity for treatment is in sub-Saharan Africa. And so as an example, for every 1 eye surgeon in Kenya, we have 100 in the UK, despite having far less blindness. And the problem is compounded further that when you go in to look at how those few surgeons are distributed throughout the country. So in Kenya, where there's only 86 ophthalmologists, half of them are based in the capital city, Nairobi, where there is the least blindness and 8% of the population. So as you get out to the more rural areas, you have a greater challenge to try and find and both provide treatment. And so because of this, in 2012, moved out to Kenya with my young family, and we ran a large cohort study. And the idea of the study was to try and work out why were people going blind, what were the causes, where were they living, who were the at-risk groups, and what could we do? To gather this kind of information was really difficult. We set up 100 different eye clinics. We used whatever buildings were available, the village chief's hut, a local school, a local church, and we'd go and we'd put all our kit in there. But getting there was really challenging. There was rarely tarmacked road, so in 70 out of the 100 clinics we went to, there was no tarmac road. This is an example of one of the clinics. So you can see here, this is where we ran the clinic, and where this picture's taken from is where we had to stop the vehicle because there was no road to get there. So it took us over an hour carrying the equipment to get it in there to be able to operate all the machines. We spent a lot of time doing this, particularly in the rainy season, and using novel ways to try and get our equipment van and our team van to where we were going. Once we did get there, we'd set up all of our high-tech kit, the kind of equipment you'd expect in a top UK hospital, because we wanted to make sure the data we were capturing was going to be valid world over so that people would accept the data that we had and base change on it. The problem is we rarely had power, so we ran most of the clinics from a petrol-powered generator or by inverting the battery on the bus. So in total, we had all this huge equipment, big team to be trained, and it was just an utter nightmare trying to actually run a clinic in those settings. And one day, whilst in preparation for one of these clinics, I went out to use the facilities, and this was the toilet. And to my surprise, as I went to use the toilet, there was somebody inside, and I heard the classic Nokia ringtone going. As the phone was going on, it just struck me that I'm in a place with no roads, there's no electricity, there's no water, but there's mobile connection. Kenya, like most of sub-Saharan Africa, has greater access to mobile phones than they do to clean running water and sanitation services. And over the last decade, as we've grown to a population above 7 billion, we've also grown to a world where it's almost ubiquitous now that mobile phone access is getting close to being 100%. So it was knowing this that we thought, can we harness mobile connectivity to deliver eye care in a new way? And that's when we came up with PEAK, which is the Portable Eye Examination Kit. The idea was to take all of the existing high-tech tests that we were delivering in the clinic and replace them with mobile solutions. And so the first thing we went about developing was something that made it possible to measure vision. Now, I'm not a developer, and so the job spec wasn't particularly attractive. It went something like this: need someone who's got lots of experience developing Android, who is willing to come and live in Kenya. We can provide them a flat with occasional electricity, where you may get electrocuted when you use it, and the pay is zero. And Stu jumped at the job opportunity, which initially was going to be a 2-week visit, and we've now been working together for the best part of 3 years. We wanted to build all of the tools that would work on the ground, and we based all of our experience and feedback on people doing the testing and the patients. So we got it wrong hundreds and thousands of times and redeveloped it again and again until it worked, so that we could test in any language and in the patient's home. And so here's an example of the vision test happening. What you're seeing is, as the E moves direction, the patient just points in the direction of the E, and the tester swipes on the screen whatever direction they're indicating. And as it gets smaller and more difficult to see, they may get to a point where they shake their head. We shake the phone to record they can't see. It becomes a very objective test because you're just recording their answer. You don't need to know if it's the right answer or the wrong answer. The phone is doing all the calculation behind that. We've now been able to test that in the field, and it's been run by people with eye care training and people with no healthcare background, and they're able to collect data of a really high standard. And it's really key to actually watch what happens in the field and learn. So here we have a grandmother having her vision tested, and behind her is her granddaughter telling her the answers. These are things you only learn when you spend time on the ground watching how people are operating the tests, and trying to take it as a test bed for improving everything that you're doing. One of the studies that we've just launched in Kenya is a study in schools where 1 in 20 children have some level of visual impairment, but to send somebody from the hospital to find that 1 in 20 is actually a very poor use of resources. So we've now trained teachers to measure vision in schools, and once they've measured the vision, they can share the information in a way that's actually intuitive to the child and to the parent. And we use something called Sight Sim, which, according to the level of vision we've just tested, gives a level of blur through the live feed on the video. So you can actually walk around, see where they should be sat, why can't they see what they're doing. And it really encourages behaviour to go and receive treatment. Once a child's been found to have impairment by the teacher, they enter the child's name, their contact phone number for the parents and the head teacher. And then what happens all behind the scenes is an SMS goes straight to the parent, telling them that your child needs to go to the hospital. The hospital has automatically received a referral to say this child is waiting to come. The head teacher gets a list of all the children in their school that should be coming for treatment. And if they don't come after 2 weeks, they start getting automated reminder SMSs in their local language, which are personalised with their name and the school that they came from. Now, out of the 300 schools in the region, we've started this trial in 50 schools, and 25 teachers are now able to screen 20,000 children in just 2 weeks. And if our trial results are positive, we're going to scale this up to be in the whole district. It's one thing to find young children that have vision problems, but it's another challenge when you go even younger. So for the kids at a very young age. So one of our co-founders here, Ian Livingston, who's always been fascinated by children's vision, here is testing his own child's vision at just a few weeks old, and I think she had a first sight test at 2 hours old. But this is using eye tracking technology and a visual stimulus that gets harder and harder to see but moves around the screen. And by seeing where the child looks, you're able to work out what their level of vision is. So we're now able to offer vision tests in languages that are language independent and at any age. Now, once you know somebody has poor vision, we need to try and work out why. And the biggest key to doing that is being able to see inside the eye. So the retina at the back of the eye has more information about the human body than any other part of it. You can see nerve tissue, so this here is a direct extension of the brain. You can see blood vessels, you can see veins, you can see arteries. But the normal ways of being able to look inside the eye, if you've ever been to your optician, requires what we, in my speciality, call a guessing stick, where you get up really close and breathe coffee breath on them, and it's a little bit too personal. And the view that you get is not great, and you have to store it in your mind. So the alternative is you have a really expensive camera, which can cost anywhere from £20,000 to £100,000, which allows you to take really good photographs of the back of the eye, which you can then share. The issue is it needs to have a stable power supply, it needs someone to operate it, and it needs quite a bit of expertise and maintenance. So that's one of our co-founders who is best described as a wizard, because he actually 3D prints his own 3D printers, purpose-built a tool which could replace the existing kit, clipping it over a phone, and this is one of our early prototypes being 3D printed. It's then built up and placed over the phone, and it makes it possible to see inside the eye, as you'll see here. Now, we tested that on over 2,000 patients as part of our study in Kenya, comparing it to standard equipment, and we continually improved the tool to get it to a point now where we're able to get images of this quality, where you can get a really nice wide view of the retina, taking in all of that information that you need. And at a 50th of the cost of the standard equipment, we found that our results are comparable to those big desktop cameras. And that was all independently verified at the leading eye hospital in the UK. But there are other advantages to having this on a smartphone. So image stitching, if any of you have ever taken a panoramic image as you sweep around, we're using a similar technology to do the same thing inside the eye, so you can build an even wider field and see more of the retina in one go. And it looks something like this as you do it. So as it pans around, it looks for features, and it starts to create a map inside the eye. These are with our partners from Optibrand. This is the RetCheck application. And it builds up a mosaic, and you get a nice wide field view of the retina. So initially, we had £100,000 worth of kit. We had 15 people to operate it. And as I said, it was a bit of a nightmare. But to do it now, you just need one person on a bike with a smartphone. And the whole thing comes in at 100th of the cost of the existing kit at a comparable level of quality. We've overcome the issue of needing a power supply by using a solar-powered rucksack, which can charge a backup battery as you go into the patient's home. And patients can be examined in their own home rather than us waiting for them never to come to the clinic. If there's sufficient bandwidth, it's possible to do telemedicine, and we've shown this doing it over Skype, where you can connect people in remote locations with experts globally sharing the information, who can then feed back with interpretation of what they've looked at. Because every patient that we see we're recording GPS data on, we're also able to work out various parameters such as why are they blind, what's the level of visual impairment, where do they live, so we can try and close the loop to make sure that they end up getting treatment on the back of that. So each red pin here is representing somebody that's blind from a condition that we can treat, and they're now contactable and traceable. We can use bulk text messaging services to ensure that people who are blind are getting information, and we make sure that there's someone key, and this again is learning from being on the ground, is a key informant, so somebody who is embedded in that community, who's responsible for people there, who can connect all of those people and make sure that they're there waiting when the bus comes to collect them, and will be the person that you'll go to arrange follow-up. So we showed you those two ladies who were blind at the beginning, and this is them after an operation that costs only £40 to £50. So she couldn't even walk before, and now she's busting some good dance moves. Thanks to our biggest funder, the Queen Elizabeth Diamond Jubilee Trust, we're now running trials and studies in 7 countries, including Botswana, Kenya, Tanzania, Mali, Malawi, India. In all of these places, we're learning how the tools can be used by different people and in different contexts to try and make sure that this is something that's relevant to what the actual need is, and to try and reduce the unnecessary avoidable blindness that's going on. And this has all been possible through collaboration. So it's been collaboration by universities, by individuals who've committed a huge amount of time. And here are some of the brilliant people that have been involved in making this a reality. I also want to say a big thank you to my wife and son who suffered a lot on our behalf. So we'd like to just show you a demo of this live now. So Stu, as well as being kind of commercial lead software developer, is also a guinea pig. So he's going to donate his eye to medical science, and we're going to give you a live demo of this now. if any of you want to have a go at this later, there's going to be a workshop in the afternoon. So if you want to come and be an eye doctor, the point of this is you need no healthcare training to be able to get a view of the back of the eye now. So if anyone comes to the workshop, Stu's going to donate his eye. You can examine him for yourself. So what we do is we you need a microphone? Can you not hear me? Okay, can you hear me now? Okay, there you go, now you can hear me. So what we do is we take this 3D printed adapter, we click it onto the phone, open the app, and all I have to do is keep Stuart's eye in the middle of the picture here. And as soon as I get in close, what it's starting to do is focus on the back of his eye. You can see now? There we go. So what I'm seeing there is Stuart's optic nerve, blood vessels, and as I move around the eye, it's capturing stills to create a panorama. So what you can see there, I'll let you focus on that, is a panorama has been built up at the inside of the eye. So we're now getting a nice wide field view of the retina.
You got loads of reflection from the other light.
Okay. So we get this really nice view inside the eye. And then I can share that. So let's imagine I'm in a remote area in Kenya and I've got this great data but I don't know what it means. So I can now share that with an expert who can feed back on what that means. So if we can go back to computer 2, I'm going to share that image now, and it should okay. So what it should be doing is picking up our GPS, and then hopefully that image is now going to come through. This never works when you do it live. There we go. Okay. So the picture we've just taken is geotagged to where the examination happened, and if I'd entered his personal details, they would all be there affiliated to this. And now, as the doctor in the clinic, I can decide to have a close look at this picture and define it as normal or abnormal, and if there's a problem, I can report that back. And so you're basically able to connect people who are currently away from access to treatment and make sure they get hold of treatment and decisions can be made, and lots of people who are unnecessarily blind can receive treatment. Just want to say a last thank you to the institutions that have been involved in supporting this, and also to the Ashoka Foundation for inviting us, and everyone who's been part of that, particularly MSpark for inviting us and supporting us here. Thank you.